So, given that background, you know that we have a lot of medication, and yet why are we not getting our patients to target? So again, I have told you that at least 50% of patients will not be able to meet the target. So different agents, even combination of them. We have several combination medication available as one pill, and yet we're not able to reach the target. Of course, we want to attain an A1C of less than 7 or your blood sugar, but then most of the time we're not even able to do that. And so this again summarizes the therapeutic effects of the commonly used drugs before the entrance of your incretin-based therapy. And of course, you know that your sulfonylureas is probably one of the most, if not the most, effective in lowering your A1C. However, it is associated with some hyperglycemia risk as well as weight gain. The same is true for your incretinides or your secretagogues and glycolides. So these three are very potent hypoglycemic agents, but they are associated with some risk. Of course, your alpha-glucosidase inhibitors has very modest, the lowering effect of your alpha-glucosidase inhibitor is not very big. And it has some GI adverse effects, flatulence and gassiness, but it can be used for many patients. Its main effect is to lower your postprandial sugars. And sometimes we have patients whose fasting sugars are quite okay, but then you check the HbA1c and it's still elevated, and sometimes we check the we actually recommend regularly checking also your postprandial sugar, and you can note that the sugars are quite high after eating. Of course, insulin has almost indefinite effect as far as lowering your sugars. However, it is injectable, obviously, and of course the risk of hyperglycemia and weight gain, which in most cases of your type 2 diabetes we don't want, because we will be worsening the problem of insulin resistance. So, in a nutshell, that's what we had before the newer drugs came in. So now we'll tackle the topic of incretin-based treatment. So what is its role? Does it have a place in the management of type 2 diabetes, and what is its possible impact on the long-term outcomes of our type 2 diabetic patients? So just showing us the importance of the beta and alpha cells. It is important to note that the endocrine portion of the pancreas is only about 1 to 5% of our pancreas. And so the significant portion of our pancreas is really exocrine. But the pancreatic islets, as I said, comprise of 1 to 5% of the total pancreas, and it is composed of both beta cells and alpha cells. Of course, we are very familiar with the beta cells because it is the one that produces insulin and co-produce amylin. So it comprises about 50% of the endocrine islets. Whereas your alpha cells, about 35%. The glucagon, which we know already from physiology from way back, is a counter-regulatory hormone. It is secreted so that in case of low sugar levels, the liver can produce sugar. So that's very important to remember. So it's a counter-regulatory hormone to insulin, and that's why glucagon is available as an emergency kit for intramuscular injection for severe hypoglycemia. We don't have that readily available in our country, but in Western countries where there are many type 1 diabetics going into hypoglycemic coma, they have already glucagon injection kit. So that's important to remember. And so we know that beta cells would release insulin in response to elevated blood sugar levels. Whereas your alpha cells, again, he said, will be releasing your glucagon in response to low blood glucose levels, and therefore it will cause increase in your blood sugar. So now we go, so what will be the usefulness of alpha cells or your glucagon levels in our discussion. So again, we know that the beta cell function in type 2 diabetes is abnormal. There are several abnormalities that we have seen. First, there is abnormal oscillatory insulin release. There is no rhythm to the release of insulin as our blood sugar varies very erratically, but more so in your type 2 diabetes. Also, there is increased pro-insulin level. Pro-insulin level is the product after your insulin is degraded. So, if your insulin is not processed properly, you will have the co-secreted hormone in higher levels. So, you have higher pro-insulin levels. And also, when you look at the type 2 diabetes response to glucose challenge, you will see that there is the loss of the first phase insulin release. We will show that in a diagrammatic form for clearer discussion. And also there is abnormal second phase insulin response. All of these abnormalities will eventually lead to progressive loss of beta cell function. So again, why is that important? Again, here is what we call the first phase insulin response. So this is normal. So when you give glucose intravenously, since your glucose level will shoot up, your body should be able to release insulin. So there's a very steep increase in your insulin